Hello and welcome to The Print. I am Sumi Sukanya Datta and we have with us today Dr. JPS Soni, Chairman of the Department of Cardiology with Gangaram Hospital. And we have Dr. Soni with us today to discuss the first ever India-specific dyslipidemia or lipid management guidelines, which has been developed by a team of 22 cardiologists associated with the Cardiology Society of India. Dr. Soni has headed the committee which came up with these guidelines. Welcome to The Print, sir. Thank you so much for talking to us.
Thank
And
you.
please share with us, sir, why exactly the need to come up with India's specific dyslipidemia guideline was felt.
Yes. You see, so far we have been following the Western guideline, mainly the European Society of Cardiology guideline 2019, which is widely accepted globally. But what we found that our population is different from rest of the world. There were certain areas we found that we should have our own guideline based on research on our own population. So why there was a need? Because we get disease 10 years earlier. Heart attack comes 10 years earlier. More than 50% of the people that die or they get heart attack below the age of 50. And around 15 to 20% people they get heart attack below the age of 40. With this figure is almost 3 times more than the Western world. Secondly, we started looking why this is happening. So when we found that the risk factors like blood pressure, diabetes, and even lipids are coming much earlier to our population. Secondly, we found we have a truncal obesity, and that central obesity, what we say metabolic syndrome, where there is a cluster of risk factor coming, again 2.5 times more common in our population compared to the Western world.
Right.
Thirdly, the tobacco area, which is the consumption, which is playing a role like cigarette smoking. But in our country, we have a unique problem about BD smoking and tobacco chewing, which also contributes to increased cardiovascular disease. And when we look into the
Right.
lipids of our country, we have a specific type of lipid where there is high triglyceride, low HDL, and the LDL cholesterol particle have got a smaller size, which enters into the formation of blockage of the artery, what we say atheroma. And genetic factors were found to be again high in our country compared to rest of the world. Like familial hypercholesterolemia has been identified in our own study in our country that more than 15% of the people with young heart attack have familial hypercholesterolemia. Because if we diagnose this condition, we can pick up the carrier of this gene in the family and prevent premature heart attack in future. Another genetic factor is lipoprotein little a, which is above 50 milligram is considered high for cardiovascular disease. Again found to be 25% of the Indian population compared to 15 to 20% Western world. Lifestyle area again we found lot of problem like physical inactivity is very high, cooking media and type of cooking which we do is again problem. We also found the healthy food of taking 3 to 5 servings of fruits and vegetables not there. But the most interesting finding which we found that significant number of people being vegetarian in our country, they consume lot of carbohydrate food, and high carbohydrate food, sweets, sweet and sugary beverages, all they contribute more to heart attack than a modest consumption of fat, healthy fat. This is what we have learned. So because of all this reason, we decided to have our own guideline based on our own population. So that was the issue which we found.
So that was about why there was need to develop India's specific guidelines. Could you now help us understand what exactly are the new elements that you're introducing in lipid management guidelines here as compared to the Western guidelines that we were following so far?
That's right. Another thing. So first, before that, let me share with you that we have recently published publication in Lancet about the prevalence of lipids in our country. We found
Right.
the high LDL above 100 milligram was present in 50% of the population. This is based on the study by Dr. Mohan on 1,13,000 population from urban and rural area. We found high cholesterol, LDL cholesterol was higher in the northern state and in the Goa and Kerala, and maybe to some extent West Bengal. And there was intrastate variation, there were inter-regional variation also. Whereas high triglyceride and low HDL cholesterol was found uniformly in whole of the country. So this was the issue which we found we are different from the rest of the world. Now coming to the question specifically, since we have high triglyceride and low HDL population, So we decided that one of the differences from the Western line was that there they say you target only LDL cholesterol. We agree with that because 80 to 90% it's the LDL target which is important, which I will discuss in more detail. But we found since we have got high atherogenic dyslipidemia, high prevalence of high triglyceride, so we decided if a person has triglyceride above 150, then we should also target non-HDL cholesterol. Because if we limit our target to LDL, we may miss a lot of remnant cardiovascular diseases and patient can develop recurrent events. And to diagnose non-HDL cholesterol is very easy to calculate that. The total cholesterol minus good cholesterol, that is called HDL cholesterol, is non-HDL cholesterol. And this non-HDL cholesterol is combination of mainly LDL cholesterol and to some extent the remnant cholesterol which is present in the triglyceride. So we calculate both the bad cholesterol present in the body. So we decided in this guideline that LDL should be target, but non-HDL should not be ignored. This is first thing what we found. And then second thing what we found that the while looking into the risk factors, the Western countries they have their own risk calculators, and if we follow their risk calculator, we underscore for our patient because our patients get disease in younger age. So according to their risk calculation, we are underscored. So that was not applicable, and since we do not have any risk calculator of our own country, we only use the risk factors. And what we added new thing was that in extremely high risk population is the one where there is a recurrent events which is coming up within 2 years. This is what the foreign guideline says. We found in our own experience there is another group of population, young heart attack patient, those who have got associated uh, genetic disorder like familial hypercholesterolemia and elevated lipoprotein little a. And in this group, we decided to keep the LDL below 40 or even going up to 30 is okay. And the non-HDL will be only 30 milligram more than that, that is around 70. In very high risk population, we did not differ with the Western guideline. It is almost same for any patient of heart attack, stroke, or long-standing diabetes to keep it below 55 and non-HDL 85. In high-risk population, we have included, like the Western guideline, the diabetes, but here in our guideline, we have given emphasis to hypertension also, that any patient with hypertension and diabetes with one of the risk factor, like risk factor of, as we said, risk factors are hypertension, diabetes, smoking, central obesity, and family history of premature heart disease. Any one of the five, if one risk factor is there and having a diabetes or hypertension, and we consider them that this should be, they should keep their LDL below 70 and non-HDL below 100. And the low risk population who do not have any risk factor or are having only single risk factor to keep it below 100, the Western guideline says 115, we say no 100 because we are getting disease even at a lower level of cholesterol than what our observation is. So expert opinion believe that in hypertensive diabetic population, try to keep it low because the final common pathway which causes the blockage of the artery is the entry of LDL or non-HDL cholesterol. And who pushes? Hypertension, diabetes, smoking, and stress. So they push them. So that's why we say the keeping it below 70, the levels, then the chances of having heart attack will be less in this diabetic and hypertensive population. The other thing which we added in our, so one was that instead of 115, we say 100. And here in diabetic and hypertension, keep it below 70. The other area which we emphasize was high triglycerides, since it is very common in our country. And we have discussed that majority of the time, the triglyceride, if a patient is diabetic, then the control of diabetic itself take care of the high triglyceride. But those who are unable to control, then lifestyle modification plays a very vital role, like regular exercise, stoppage of smoking and alcohol, reduction of carbohydrate food, weight reduction, all those factors, they reduce triglyceride to a large extent. But those who have got triglyceride high, but they're having heart disease or they're having diabetes, there we suggested to give them statin and non-statin group of drugs or maybe fish oil, only EPA of the fish oil. Those who got very high triglyceride above 500, their fenofibrate, saroglitazone is our own country drug, which we have recommended and along with fish oil. Now, the management part, we differ a little bit with that we said for a patient of heart attack, when he comes to us, we have said that hit hard and hit early. What does it mean is that in heart attack patient, we should bring the LDL cholesterol to below 55 as early as possible. Otherwise, there will be chances of recurrent coronary events or recurrent heart attack. And for that reason, we based on our own study, we suggested that in patient whose LDL cholesterol is above 100, to give them a combination treatment of statin and non-statin drug. The non-statin drugs are easily available, azithromycin and bempedoic acid also, and we found that all of these statin and non-statin drugs, they reduce LDL cholesterol. 1 millimole reduction, what is 40 milligram reduction, reduces cardiovascular event by 20 to 23%, irrespective whether it is a statin or non-statin. The reduction of LDL is important. So we decided to combine both the drugs together, one acting on the liver, the other acting on the intestine. So by dual pathway, we reach the goal of LDL below 55 early and safely. This is what we have seen. And so this is the decision. And then we have now injectable lipid lowering drugs also available, like PCSK9 inhibitor, which has to be given 26 injections a year. And now inclisiran has come, which has to be given only 2 injections per year. And they're both very effective and very safe drug. Can be given to patients, those who are not tolerating statin. Those who do not tolerate statin, we give them azithromycin and bempedoic acid also. And finally, the area where we have found we differ was the genetic area. And in that, we found that familial hypercholesterolemia, that heart attack coming in young age with family history positive, little high cholesterol, and certain clinical findings we look into ARCUS. And if we make a clinical diagnosis of familial hypercholesterolemia, the importance is that we not only treat the index case, but this patient is, his family is at risk. So what we do, lipid profile is done for their children and their brother and sister. And if the levels are high, we consider them that they are a carrier and they should be treated early so that we can prevent future cardiovascular disease.
Yeah. So a lot of emphasis, I was going through the guidelines. I have seen that a lot of emphasis has been placed on taking medicines when required to manage the lipids. Is that because in your clinical practice or the cardiologists who have come together to frame these guidelines are seeing that misinformation, sometimes over reliance on alternate therapies is becoming too much of a public health problem, and individuals are really taking things into their hands? Is this what you're observing in your practice as well?
I think that you're right. In our practice, we found two things. Looking into the therapy, which when the doctor prescribes statin in the dose to our patient, we found down the line as the time passes, the many patients they reduce the dose, or their doctor reduce the dose, or they even stop the drug. The what we found when we analyzed the data of our country and our hospital patient, we found one of the reason which we asked them, what is there any side effect you are having? Yes, 5 to 10% people can have myalgia, some muscle pain, which is true that we can reduce the dose or change give to the other alternative drug. Second factor, without any reason, they reduce the drug. Cost is not a big factor because the most of the drugs in our country are generic now. They're very
Mhm.
cost effective. And thirdly, they did come up that in the media, in social media, many times people say the cholesterol is not important, the statin is not a good drug, it causes a lot of side effects. And that probably gives them an idea that we can reduce the drug. So the compliance and adherence to the drug therapy is a big challenge globally, but more in our country, what we have seen. The other thing is the alternative treatment. Yes, many times we have seen the alternative group of treatment that which have not been studied. There is no evidence of those drugs, whether they reduce cholesterol or not. Although there are certain nutraceutical available, people are using garlic or berberine or Chinese red yeast rice. These are the nutraceutical. They are also known to reduce cholesterol, but they have not been supported by clinical trials whether they reduce cardiovascular events or not. They do reduce cholesterol to some extent. Probably safer drug, but we generally do not recommend as a first line drug, maybe additive drug along with the statin. So those, I think, alternative medicine also plays a significant role because by giving that drugs, these drugs are never very powerful drugs. They're not very effective. So the people, most of the people will not able to reach the goal which we have told the patient that we should have keep this goal level. The other important thing which I want to emphasize that in our country, the laboratories, the clinical biochemistry laboratory in the country, when we go to the lipid profile report, you will find there will be variable reference range. For example, I give the now the reference what we give for general public is to keep LDL below 100 and non-HDL below 130. Now, if you look into the various laboratories, and maybe more than 3 lakh laboratories are there, very few of them are NABL accredited. But you can find that variable reports. I mean, they will write reference range 70 to 140, 80 to 110, something like that. So what happens? A patient as a whole gets is misled by this report. Now, I will give you one example that one of my patient who came to me only day for yesterday, I asked him to get his lipid profile. He had a heart attack few years ago. So I asked him. He came to me after a long time. I asked him to go for lipid profile, and then he came to me with the LDL of 90. एंड ही सेज डॉक्टर साहब मेरा सब कुछ कंट्रोल है मेरा लिपिड्स बिल्कुल नॉर्मल है मैं 90 हूं आपने लिखा हुआ 100 से नीचे होना चाहिए आई एम फाइन आई सेड नो यू आर ए पेशेंट ऑफ हार्ट अटैक no that's why we decided for all the laboratories they should give a small table below
Should
where they
below
should look
45 is the main case.
yeah, we should give them an idea that you should look for your risk and your LDL goal. Two things. So what we have done, we have given the low risk, high risk, very high risk, and accordingly we have given the LDL goal. So this patient, for example, who had 90 milligram, when he comes, since he's a heart attack patient, he belongs to very high risk, and in very high risk group column, you find the LDL has to be less than 55. So we
Right.
need to step up his statin drug or add non-statin drugs to reach the goal. If you don't do that, 90 milligram patient will get recurrent attacks. He will get reblockage of the arteries. So this is another area in our guideline which we have emphasized that the country will, because many of the patients are getting recurrent diseases because they look into the report and they feel they are happy. They feel they are well controlled, which is not. So this
Yeah.
message we are giving to the public.
Yeah, very important points there. So to wrap up the conversation, one last question from my side. We keep seeing these images, these videos of people just normal who seemingly appearing normal people, they just collapse. One
Yes.
find it in gyms, in offices, in banks, everywhere, and there is suddenly this very many people are very anxious that the rates of heart attacks, particularly among young, are really rising. Do you really think what in your assessments or what exactly is the reason? Is it related to COVID, or it was happening before but now because of the social media with the everybody with the camera in their hand can just record, CCTVs capturing it, that's why we are seeing it more? What is your assessment, sir?
That's right. It is certainly one answer is that it is not COVID. It is simple answer is that even you have because you can see the news coming from Bollywood, from the cricketers, from many players, such type of news coming, young people getting heart attack or suddenly collapsing in marathon and all that. Now what we found, it is nothing but lipid. Because what happened, hypertension has some symptom, blood sugar has some symptom, cholesterol has no symptom. It is a true silent killer. If you look into the data of my
Suddenly,
some of my
over the
these
last
people,
4 or 5 years, suddenly, do you think the lipid numbers have really gone haywire for so many people that it's happening more now?
no,
Could
that's
be.
what you see. They when we ask our patient or this some of these top players or Bollywood actors, they have everything known. When we ask them what is your lipid profile, they are not aware what has happened to them to their lipid profile. And this lipid profile is important because it's silent number one, and this plays through the family history. And majority of the people, those who got young heart attack in cricketers and all that, when we go into their history, we found there was a family history of premature disease in that. And that is a very important clue. If your father getting heart attack below 55, mother below 65, this is young heart attack. And if it is there, and if you are not a smoker or diabetic, then think it is nothing but a genetic disease, probably a polygenic genetic disease where there is an increased cholesterol level which has not been identified. And this is my experience. What I can say, this is my takeaway that most of the people. That's why what we have suggested in our guideline. Another important thing that the age of 18 years should be the first lipid profile done for everybody. When a child goes to college, he should know his sugar, he should know his blood pressure, but he should know his lipid profile. This is very important. And for patients whose parents have got heart attack in a younger age, they should get it in very young age, up to 5 years, 6 years, we are recommending to get the lipid profile because there may be genetic carrier and we can save their life from getting premature heart attack. So one, getting it 18 years. Second, if they know the lipid levels, then probably you'll able to manage them the way we are managing hypertension and diabetes. We're ignoring lipid. And this young heart attack population, young collapse population, majority of them are premature, family history of premature heart disease and high lipid level, which was ignored because they are not aware of that. And this lipid kept on accumulating in the body, and finally they had rupture of the plaque and had sudden heart attack and they died. Most
Okay.
of the deaths are because of heart attack.
Yeah, yeah, that's very crucial information that our viewers can benefit from. Thank you so much, sir, for joining us in the conversation today.
Thank you very much
Thank
for
you so
giving me
much.
this opportunity to share our views of our guideline, which is the first guideline in our country on lipids, and giving the emphasis to the general public that please look after your lipid profile. It cannot be known unless until you do the test for that. And nowadays, we also suggested the non-fasting lipid profile is good enough because that makes a lot of difference. Because total
Mhm.
cholesterol, HDL cholesterol, LDL cholesterol, nothing changes with fasting or non-fasting state. Only thing which
Yeah,
changes is triglyceride, and those who have got very high triglyceride, already known case, there we ask them to go for fasting state. Whereas
yeah,
most of the people, and this helps us not only to increase the number of patients getting lipid profile and unnecessarily crowding in the labs in the
yeah,
morning with fasting state. That makes situation more difficult. So those
yeah.
things that these are the important thing we say. Non-fasting lipid start
So
at
lipid
80. It is a
basically
silent
can be
killer.
done at any point of the day. It doesn't have to be fasting, right? That is the
No,
message.
doesn't have to be fasting. That is very
Yeah,
important message which we gave in our guideline.
yeah. Thank you so much, sir. Thank you so much for joining the conversation.
Thank you, Sumi. Thank you very much for giving us the opportunity.